So Dr. Patel has been in private practice since 95, although everybody believes that she's lying about that because I don't think she's old enough to be practicing since 95.
I have to, I'm going to jump in, actually 1991, because I practiced in England in 91.
Okay, so we're just trying to get closer to the truth. So she's been doing sleep for 5 years. She's known as the snoozologist. And she recently sold her general practice and sleep practice and is now doing this, coaching teams and doctors like you all for the benefit of you and your teams. So we want to be here to host this tonight. Awaken to Sleep is the host. We want to give a shout out to Kettenbach and thank you all for supporting this education tonight. They've got some great tools with their airway metrics kits and stuff like that. So anyway, I want to say hello to the folks that did say hi. We got Nicole from Elkin, North Carolina, cool. Fernando in Panama, Amy in Nebraska. No one from the West Coast is holding it down. Man, they got no excuses either. I mean, come on, it's like 5:05 here. Maybe they're still working. They'll get here in a few minutes.
Anyone from Florida? That's where I'm at right now. I don't see, oh, from Nashville. Oh, I love Nashville. Oh my gosh, such good food too and music. Man, I gotta go.
All right. So reminder, guys and gals, Q&A for all your billing questions. If you've got any issues with tech stuff or answering Mona's questions, please hit us in the chat. Otherwise, I will get out of the way. Mona, have some fun.
Take it away. All right.
Take it away.
Awesome. Hi, everyone. I'm Mona Patel. I was in clinical practice for about 30 years. And, you know, last year I left my practice and moved to Florida. And in the meantime, the last couple of years, I started to teach how to implement dental sleep medicine and really kind of put it into place for teams and doctors. My career has always been about comprehensive dental care, not just teeth and gums, but joints, muscles. And I knew there was a missing piece. And I found it about 8 years ago. That was when I was diagnosed with mild sleep apnea without looking to be diagnosed for it. I was at a sleep course and I got tested and that was my diagnosis. And it kind of opened up a whole door of learning and feeling better and learning how to recognize it, discuss it with patients and getting them to go through the steps and getting the right treatment option for them. Because when I did that for myself, I felt 100 times better. What I did find is that when you're looking at putting a dental sleep medicine program into your practice, especially if you are a restorative dentist, we forget when there's sometimes we go to sleep courses and it is all about from a point of view of a dental sleep practice primarily, not doing restorative. And that's a whole different kettle of fish. But when you're in a restorative practice implementing sleep medicine, that's different and it's challenging. And I wanted to share a few thoughts on how do you get paid for this? Number one, how do you make it less overwhelming? Because there's such a big connection between dental sleep medicine and medical insurance. It's like, it's almost everyone thinks it goes hand in hand and you cannot do dental sleep medicine without medical insurance. So I wanted to share with you why I stopped doing it and what happened when I did. So, you know, a little bit again about what I do now, and that is I coach. I have a company called Dental Snoozology, and I'm also a coach for Awaken to Sleep. So you've heard a little bit about me, but I wanted to kind of share a quick story about a patient. And this was a patient who I'd known since he was 5 years old. And I'd watched him grow up and he had orthodontics. He went through to, you know, the retainer stage and was wearing retainers. And then he broke the retainers and we made him a night guard. And then, you know, little Joey, well, big Joey went off to college and he went off to college and he came back and I didn't see him for a couple of years because, you know, he was 23, he was in construction. It was hard for him to kind of put his dental health care first until he broke his night guard, right? And he came in, and at that point, he said, "Can you fix my night guard?" And I looked at him, and I'm like, "Absolutely, Joey. Let me just check your medical history because I haven't seen you for a couple of years." And I was so surprised to find that he was on a hypertensive medication, which to me was astounding, that I have a 23-year-old healthy male and he's on blood pressure medication, but his blood pressure was running high, so his doctor put him on a med. And I explained to Joey about the connection between health and sleep, and we tested him for sleep issues, and he came back with a diagnosis of mild sleep apnea, and we made him an appliance. And we made him an appliance. He didn't have medical insurance. So what did? We just billed him privately, and he paid for it because he understood that he would rather look after his wellness now rather than be committed to having a ton of medications in the future. So I just wanted to share that story because it just, number one, drives home how important what we do by screening our patients and teaching them about their health. And number two, we can do these things without putting unnecessary obstacles in our way. So when we look at this slide, this is really a process that we see in a restorative dental sleep medicine office. You know, we're identifying those at risk in our office, be it new patients, be it existing patients, right? We assess the severity and the presence of the condition by referring out or administering home sleep tests ourselves, and then we treat them with a clinically appropriate treatment. So if you notice on the third where it says treat, there's medical billing. And I'd like to share with you tonight why our team removed medical billing from the treatment step. Now, please don't misunderstand me. I'm not anti-medical billing. I think that it has a place in our world, in our dental practices for sure. But I want to change or shift the mindset that when we first start putting this into place for our patients, our dental sleep medicine process, what can make it more successful for your patients and less overwhelming for your team. So reason number one, complexity. I think that a lot of dentists don't really understand what we're agreeing to when we start to introduce medical billing. There's a lot of questions we have to ask ourselves. And these questions can be overwhelming because you're doing restorative dentistry, you're doing hygiene, you're doing many different dental procedures, and then you suddenly have to take your dental hat off and put a medical hat on and talk to a patient about health and sleep apnea and home sleep testing and all of those things. So when you first decide to do dental sleep medicine, it is super important to clarify how you want to be paid for this. What do you need to consider? If you're a restorative practice only, do you want to start medical billing and implementing dental sleep medicine? That's two big processes to put into place. If you are considering medical, are you going to bill out the medical yourself? So do you have enough team members to do that? Do you have, do they have enough comfort level? Do you have enough man hours to call the companies or be online and do research for it? Or are you going to be using a third party billing service? And what are the setup costs for that? What will they do? How will they be paid? Is there a setup fee? The next question when you talk about medical billing is, will you be in network with the medical insurances, or will you choose to be out of network? If you're going to be in network, will that affect the dental part of your practice? Because some medical insurances, if you're in network with a medical insurance, you automatically are going to be in network with dental, which changes how you're going to be paid on the dental end of things. The other question is Medicare. Are you going to take Medicare on? A lot of your patients, like mine, were older. They were, over 65 and they had Medicare benefits. Did I make appliances for them? Absolutely. Did I work with Medicare? No, they paid privately. And it's all about treatment acceptance and needs and value. But with Medicare, what you want to know is what's your state allowance? And do you want to be completely participating, which means that you only bill for the state allowance? Or do you want to be non-participating where you'll be paid the allowance by the Medicare, and then you can bill the rest to the patient or bill to their supplemental insurance? But in doing that, who in your office is going to track this? Do you have enough manpower to do this? Do you have enough people in your office to be able to track and cover all of the little check boxes that you need to for it? The other option is, being private, which is simple for sure. It's great. You collect your full fee ahead of time, and it's less work for your team. But what's the downside? When you start to work with medical professionals outside of your office, the referrals, medical physicians, MDs, they want to know if you're accepting medical insurance. That's one of the first things that they might ask you. So you have to kind of balance out the pros and cons. If you were completely going into a dental sleep medicine practice with no restorative on that side, of course, working with medical insurance is huge. That's going to be a big part of your practice. It's because your practice is going to have referrals coming to you. So you'd want to be open to medical. But in a dental restorative practice, it might be a little difficult to introduce that. Patient expectations.
Hey, Mona.
Yeah.
I apologize. Can you go back one slide? We had a very specific question from George on that last one. He said, speaking of supplemental insurance, would you quickly cover the difference between that and secondary insurance?
So in Medicare, they call it supplemental insurance. So a lot of Medicare patients have supplementals with of different levels. So when you have your Medicare payment, you can then go ahead and bill to supplemental insurance. It's very similar to secondary dental insurance. So if you have primary dental insurance and secondary dental insurance, it's pretty much a similar thing.
Yeah.
Hopefully that answers the question.
Yeah, no, that's good. And I'll add one more tidbit to it. There are some folks that they will call it supplemental, and it's actually not. As what Mona just shared, it's a secondary PPO. So if they had benefits when they retired from their job and they have benefits for life or for a certain time period after retirement, it can be a full PPO insurance plan that is secondary to Medicare as their primary. In that case, that plan has the potential of covering much higher than just the Medicare allowed amount if you're non-par, like what Mona had shared.
Yeah, but again, with supplemental too, you can go ahead, you have to bill to Medicare first. Correct, Michael?
Yes.
Even if it's a secondary insurance or if it's a supplemental, you can't skip the Medicare part.
Yep. Yeah. Cool. Thank you.
So the second reason is patient expectations. So patients really do expect that they don't have to pay anything when you speak about medical insurance because of their experience with their medical procedures, going into hospital medical offices. And we actually create that or enhance that thought process because if we lead with medical insurance, we're kind of, corroborating that thought. In dental sleep medicine-based offices, the volume and outside referrals play a big part in all of this. So it's really normal to lead with insurance. It's just a whole different setup. It is much more of a medically based setup. Patients know why they're coming to you. They're being referred from sleep MDs. You can, talk about medical insurance on the phone. And the issue is when you're screening your restorative practice, you've got to really place the emphasis on health versus insurance. And when you do that, that can be a game changer. And how do I know that? My experience. So when I first started out in dental sleep medicine, I went to a ton of courses. I put in a ton of hours of CE. And I really thought, because this was the consensus, was just, I have to have medical billing. Now, in my practice, I was fee for service, and I was generally talking about treatment plans that were way over the patient's maximum insurance for that time. So we had people accepting treatment of 5,000, 10,000, 15,000, especially if you were doing bigger aesthetic cases. And that wasn't an issue. But what we were finding is that with our sleep patients, for some reason, when it came to accepting treatment, we were getting very low case acceptances, and we couldn't figure it out because they knew us, they've been with us for a long time. But what was the disconnect? And then I realized it's that I'm doing something completely opposite to what I've always done in dentistry. And that's leading with an insurance conversation. So we changed that. And when I did, and we led with going over and having an amazing consult to go over the sleep study, to really explain to the patient what they're seeing on the study, if they have an AHI of 15, what does that really mean to them? That they're choking 15 times an hour, and why? And how it's connected to their hypertension, or how they're feeling, or they're snoring. And once we started to switch things to that conversation, the treatment acceptance actually got much higher, because we're now showing them the issue. They were seeing that there's the problem, we're offering a solution, and they're accepting the solution. And we would get patients to schedule their treatment without even having a financial conversation. We'd schedule them with their records after we've done a consult, and they'd go and have that financial conversation with our office manager. So again, medical insurance, what happens is, in the medical model, you collect a small copay. And if anything else, you'll mail the bill. So when we lead with that, it changes things. Patients believe that medical is going to cover it. And if they don't cover it, maybe I don't need it. So let's talk about some of the obstacles when it does come to medical billing. And it's a different language that we have to learn. It's not impossible. And there's some great third-party billers out there. There's some great courses on medical billing. But if you're starting out and you're putting dental sleep medicine into your practice, that's one different language for you and your team. Now, do you want to add another language when it comes to medical insurances? So what's interesting is 2 out of 3 insurance plans have deductibles over the average oral appliance fee. And interestingly enough, they did a national average for oral appliances, and the national average is about $2,500. And deductibles, 2 out of 3 plans have deductibles over that. $5,000 is kind of becoming the norm. $10,000 is also not unheard of. Now, if the patient has used their deductible, their insurance might kick in. But if they haven't, and you don't know that, So I was coaching a client recently, and she wanted to have some clarification on her billing process. She wanted to kind of get rid of medical billing in her office until they really had the flow of their dental sleep medicine in place. And one of the things that really pushed it towards that was she was so excited that she got a patient to have a sleep test, to have the diagnosis. The MD gave her all the necessary paperwork, and she got the yes to make an appliance, and called up the medical insurance company, got a yes. But guess what? They didn't find out if the patient had met the deductible, and he hadn't. So she was charging $3,500 for her appliance. He had to pay the whole amount. So even though he was feeling better, he was so unhappy. And that left a bad taste for him, because he lost sight of the fact that he actually is getting better. And for her, it just was disheartening that she kind of slowed down her dental sleep process. So when again, when you think about deductibles, don't forget to find out if you're going to do medical billing. Don't forget to find out if the patient's met it. Again, a lot of patients really don't go to their PCP that often and might not have met their deductible. And so don't be caught like my client. Let's talk about gap coverage. What's gap coverage? And it's not where you go by jeans or hoodies or anything like that. Gap coverage allows you as an out of network provider to be in network with a medical company for about 6 weeks in order for you to be able to make an appliance so that it can be covered. The problem is that you have to go through hoops to get gap coverage. You can't start it. Sometimes the patient has to start it. Sometimes their PCP has to start it. It's again, adding to a lot of challenges and elongating the process. Here you've built the fire for your patient. You have sleep apnea, you're choking at nighttime, you're not sleeping. And now let's wait a few weeks until we get an okay that you have a gap coverage to be able to make your appliance. Reason number 4, going into workflow and timeline. So one of the things that I really, if you are stepping into this and you want to think about doing medical, is that you do need to follow some specific steps. You have to do a verification of benefits. Yep, just like dental insurance. But that is so important because it's going to tell you if you need a pre-authorization. Well, a pre-authorization is very different from a dental predetermination. A pre-auth is required by most of the medical insurance companies. And if you skip that step, you're pretty much not going to get coverage for your appliance. You're going to have to find out, is their policy active? Is it a HMO policy? Is it a PPO? Because that changes coverages. Is there a co-insurance? Does the patient owe any deductible? So who finds all of this out? Do you have a dedicated team member that's going to be able to call and be on the phone and find all of that out? Or do you want to give it to a third-party biller? Well, do you have a team member to upload all the information to the third party to be able to look into it? And then once you have that information, you now have to do a pre-auth. And like I said, if you skip it, that's an automatic no. But you're also, for doing a pre-auth, you're going to need a ton of different forms. You're going to need SOAP notes. You're going to need diagnosis codes. You're going to need a procedure code. You need a treatment plan. You're going to need your home sleep test. You're going to need your prescription and all of those things. So there's a lot of steps to be able to get to the actual yes of helping your patients. And what I found in my practice was it's doable, but it's complicated the workflow. My team members were not super comfortable with that medical flow. And even despite training them and giving them tools on it, they were hesitant because they were coming from a dental background and they were unsure about some of the medical verbiage. And you can always go ahead and find training for your team. But at the beginning, once I switched to just a nice, normal conversation about fee for service, private fee instead of medical, gosh, things turned around even with my team. They were just more on board with it. They were more comfortable and were able to get patients on board with their financial arrangements. Yes, Michael.
Yeah, a couple of questions since they're coming in and you hit a couple of these topics. So I want to ask, one is about gap. So you just covered getting a gap exception. Sometimes you can initiate it as the dental office. Sometimes the patient has to, sometimes the referring MD has to, all that. But the question is getting a gap exception beneficial to the patient or to my practice or both, and why?
The gap allows you to bill a medical insurance company. So when you try to work with medical insurance, some of the insurance companies won't allow you to get any benefits for the patient because you're not in network. So a gap provision allows you to become temporarily in network for, I think it's about 6 weeks to allow you to make the appliance and get in-network coverage for that appliance. So it's a temporary in for you to be able to build a medical company.
Yep. And it is a benefit to the practice. I know you said this earlier, but just a reminder for the question. It's a benefit to the practice because your out-of-network fee is now processed as in-network. So it gets you higher percentage coverage on that coinsurance. Cool. Thank you for that. There was another one, but I'm going to hang on to it because it is a massive question. So I'll get out of your way. Go ahead. I'll matriculate it down and get back to you. Thank you.
Awesome. Yeah. So medical billing can definitely add value for your patient. But again, like I said, it's really what model are you working with? And when you're first starting out, putting this into place, you're screening, you're going to have your hygienists have discussions with patients. You're now then going to have them either being referred out or really accepting a home sleep test administered by your office if the state allows, and then having that report read by a sleep MD and coming back with a diagnosis. Your focus should be on that workflow and then the clinical workflow, because what records do you take? How do you take a therapeutic bite? For an appliance, what appliance do I do? What do I need when I'm doing a follow-up? What do I ask? Like that workflow is so important. Now, if you're layering it on with, okay, do they have deductibles? Do they have, do we need to do a gap? Do we need a pre-auth? It becomes very process heavy. And you have to ask yourself, is your team ready for that? Are you able to train your team on that? If you're completely DSM, then medical insurance is going to be the big part of your setup. But if you're a restorative practice implementing this process, you need a plan. But it's also how much time does your team have? And one of the things that I'm finding post-COVID is that there's a lack of team members in the office. So how are you going to be most efficient with your team when it comes to implementing this? And then, being stressed about medical billing and the verbiage that goes with it and the workflow with that might not be a great way to actually implement your dental sleep medicine process in there. What I did find is that once we started to do the screening, the consultation and everything without the emphasis on medical billing, and our case acceptance went up, slowly, the comfort of the flow and knowing what we were doing with each appointment allowed us then to feel comfortable opening up, introducing medical billing into our office. We came up with a nice hybrid flow where we definitely were, cash fee, and then provided a complimentary courtesy to our patients about medical billing, and we would look into their benefits, and if they had it and their deductible was met, and if they wanted us to pursue it, we would. So it kind of like became the best of both worlds, but we couldn't think to do that at the beginning because it was so overwhelming. So the other thing to do is to make a note that know what codes you have to use and what forms. And remember that if you're going to do medical billing through your office and not use a third-party service, you need at least 2 different diagnosis codes, not just the G47.33 for OSA. You're going to need to have an additional like macroglossia, large tongue or snoring. You also want to remember that you're going to bill for an EO 486, which is the medical code for a sleep appliance. And this code also includes a 90-day follow-up care, okay? I'm also hearing is that a sleep study for Medicare, a sleep study cannot be any older than 12 months prior to delivery. And some of the medical insurances are now, they follow Medicare. And so make sure that your sleep study is up to date and within the 12-month period for when you're working with medical insurance. So these are some fun codes. Would it surprise you to know that medical insurance is available for certain situations, such as relationship issues with your in-laws? I'm just wondering if you would need a pre-auth for being struck by a macaw for the first time. And apparently there's medical codes for a second or subsequent encounter for being struck by a duck. I don't know how that would happen to a person twice. I don't know if you guys ever see it. Please send me through Messenger.
There's
Video.
viral videos of Canadian geese attacking people repeatedly. I'm just saying, like,
But
that's
wait,
probably the most valid one on that list.
but wait, so the Canadian geese and a duck, I mean, you know, the insurance company is going to fight that.
That's hilarious. Mona, I do have another question for you.
Yeah.
This is why I hopped on outside of the ducks. So question is, what's the difference between the ICD-10 codes, the diagnosis codes you're just mentioning, and the CPT codes, like two sets of codes? That's not how it is in dental. What's the difference? You have the
you have a diagnosis code and then you have a procedure code. And that's the difference. And they go hand in hand. You can't have just one, the other. Yeah.
Yep. One is what and the other is why.
Which we don't, we don't have that in dentistry at all.
No.
Yeah. So it's like you have OSA because you have a big tongue that's blocking the airway. So the code for OSA and then the code for macroglossia.
Yeah. And one other tidbit, guys, Medicare specifically has a set of 7 comorbidities that they require in order to cover treatment if you have a mild diagnosis. So just a FYI on that. Mona already mentioned some of that. An Epworth scale greater than 11, ischemic heart disease, that stuff is on there.
Yeah. I mean, if you had someone with mild and moderate and they had comorbidities and an Epworth of 7, of 11 or more, you're definitely going to be more likely to get coverage. But if you have someone with mild apnea but no comorbidities and they score themselves on the Epworth under 11, it's going to be tough.
Yeah.
Yeah.
And don't add any of the comorbidities on this slide because they will not help you get coverage for your obstructive sleep apnea plan.
Not at all. So our treatment plan should not change based on what's covered, right? We know that in every day in what we do in dentistry. And, you know, we're always fighting the good fight of educating our patients on why treatment is needed. And it may not all be covered by insurance, but treatment, that doesn't change your treatment plan. And again, I can't hit home hard enough. Leading with the insurance coverage can definitely give the wrong message to a patient. We really need to build value and help them see why they need what they do. It's really like we need to help them want what they need to make their lives better, to live longer, to sleep better, to feel better. So I can't emphasize enough how shifting, and this is not just for my office, for a lot of the offices that I've coached, shifting that mindset and leading with the health, the value, and getting the patient to see this is the solution for them. That makes a huge difference in case acceptance. So how did we talk to patients about the fee? So one of the biggest things that I want you to take away is we are not selling an appliance. You're not selling a piece of plastic, right? We're selling airway therapy. We are selling a comprehensive airway package. And in the financial conversation, it's great to have this comprehensive treatment plan. We set one fee, but we build such a tremendous value and work with this patient to move forward. Like in my office, I always had packages for everything, and sleep was a comprehensive airway package Who doesn't love packages? You know, people love it. Like they feel like getting more value when we bundle it together. And, you know, we prioritize the value of the treatment. So we would lay out all the different appointments that we had, and we would list in each appointment what we were doing to build the value. We definitely help see the patients that for this process to get them from A to B, from, you know, the diagnosis to getting them into an appliance, if they chose the appliance and if that was the right treatment option for them, they're going to need a few appointments. They're going to need follow-ups. We're not going to charge them for each follow-up. What we're going to do is we're going to bundle it together and give them a package, an airway package for their airway therapy. It's how I discussed, you know, comprehensive dentistry. If I was doing a full mouth rehab, I wouldn't put line items. It would be, this case is X amount of dollars, and included is XYZ, and these are how many appointments, and this is how you would make the financial arrangement. And that simplified it. People understood it, because a lot of times people just wanted to know what the logistics of this were. You know, do they just come in and get the appliance and do they go? No. And when you show them the set of appointments, and then also the need for an annual checkup to make sure that everything's working well, we're evaluating their appliance, we're making sure they're wearing their morning aligner, we're looking at their muscles in TMD. It's huge in case acceptance. This is part of it blown up, but you can see I really line itemed the value of it, what we do, what we want to check. And it really made a big difference for people knowing how many appointments. And if they were on that journey and they got lost in it, they would just go back to their appointments, go, oh, I know where I am. And it was a great way of getting patient acceptance. So we build a comprehensive package, and that's what I would really advise you guys to do that. People and do it for everything. And then, I mean, I had one for my perio, for my implants, for occlusion, for TMD. It just was the simplest way to be able to explain the treatment, the appointments, and the cost. And remember, we use medical insurance as a tool, not as a decision maker. We use it as a tool to help them if they have benefits. So we would always present this comprehensive airway package, but at the end of it, my office manager would be able to say, hey, this is great. You're eligible for the comprehensive airway package, but it looks like you have medical insurance. So if it's okay with you, let me go ahead and do a pre-auth and see if you need it, you know, what you need to get coverage. And if they did have coverage, she'd call them and say, hey, great news. It looks like you have some coverage. I don't know how much it's going to be, but you've already, you know, enrolled in the comprehensive airway package. And if we get the check from the medical insurance, we'll reimburse you. And if they didn't have coverage, you'd call them and say, hey, it was worth a try. You don't have coverage for this, but the great news is you're still eligible for our comprehensive airway package and all of the appointments and all of the follow-ups that are included in it. Just created such big value for it.
Hey, Mona, before you move on, I want to just highlight a couple of things that you just said that I want to make sure the audience hears it. We don't glaze over it. Your comprehensive airway package is awesome. It's a package, not a piece of plastic. You highlighted care versus coverage. There's a big difference between what's covered versus the care that people want, the care that you're going to offer, and that's what comes in the package. So that big difference is there. And then you said something just at the end there, you're eligible for this. The word eligible automatically triggers in a patient's mind, like, this is what my insurance covers. So saying that they're still eligible for something, that's on money.
Yeah, it's carefully used words to help connect the patient to what we're getting them to do. You know, it's it's not Jedi mind tricks or manipulation, but we're just helping them understand what they're able to benefit from. So yeah.
Got it.
Yeah. So, again, going back to that, our purpose is really to help people, and you use whatever approach allows you to be a sleep advocate, to help more people, because that's why we're choosing to do this. We're in a perfect place to do it. But we have to be able to do it where our well doesn't run dry, where we're not stressed, we're not overwhelmed, we're not overwhelming our team, and they're not shutting down, and then it spreads into the rest of the office. So, ask yourself, what type of practice are you putting this into? What is your long-term outcome for it? How do you want to start and put in a carefully tiered plan? Put in dental sleep medicine, then figure out what the next step is when it comes to medical, and then being in network and Medicare. And so don't try and build everything in all together and make a hodgepodge of things. Just carefully planned, a little bit at a time. Get really good initially at your clinical process, at your workflow, at your screening, obtaining the testing and the diagnosis, and then getting to, how you're being paid for it.
With a bow on top, I don't know how to follow that, but I have a lot of questions.
Oh gosh.
And
Okay.
I know,
Yeah.
let's get through a couple of them. I know you've got a couple of more slides as well, so I want to make sure we get through those. But
Okay.
okay, so Robert had a question: is the sleep study timeline of 1 year only for insurance? Is the sleep study timeline of 1 year only for insurance?
Me personally, I would agree with that. I always wanted my patients to have a sleep study done within a year, because I want to get a good basic sleep study, and I want to compare apples to apples when I make an appliance and when I am comparing the studies, right? So something 2 years old could be when the patient was 10 pounds thinner and not as bad. And now I'm making them an appliance, they've put on weight, they've got some systemic issues. Am I really comparing two similar studies? So in my mind, I firmly believe in having comparable studies. If you choose to have a sleep study, like I got mine from Awaken to Sleep, where the disposables are super cheap, but the reports are amazing. And what that means is that if I had a patient who had done a sleep study and didn't want to go back and redo it, sometimes I would just have them do it. And I wouldn't charge them, but now I've got something to compare when I'm doing my titration comparisons. So, yeah.
Yeah. And Mona, I think you're on the money. And Robert, I'd add to that. This is the study you're being compared against. So it's in not just the patient's best interest, but also yours as the treating doctor. Make sure that you have an apples to apples comparison. And I know some of your situation and some others here on the webinar tonight, if you guys are referring, or pardon me, if you're getting referrals from MDs and they are managing the diagnosis and the efficacy testing, and you're just doing your quote unquote job of treating the patient, man, I would do an HST on your own equipment that doesn't get read by an MD because that diagnosis has already been made. I would get a titration test right out of the gate in their diagnostic position of no treatment, just to see what you're dealing with. And then you can compare apples to apples on your own home sleep test. That's just me.
No, I agree. I mean, even if I had, sometimes sleep MDs refer you patients, and the tests that they use, yeah, they give you an AHI, but they don't give you the length of apneas and hypopneas. They don't give you an RDI, which is so important for dentists when it comes to upper airway resistance and bruxism. I just would have them repeat the test with mine in office. And then I would just get a great report from Awaken to Sleep's interp. And it was just, now I felt like I was on an even playing field. I knew exactly where I was as I started treatment.
Yeah, cool. Okay, so a couple more. Nicole asked, pretty pleased with sugar on top. Can we get a copy of the comprehensive? Airway package.
Yeah. Um, we'll talk to Nicole because it's usually for my snoozology clients, but we'll talk about it. Yeah.
Cool. I got a few more here. You started with medical insurance and then went to fee for service.
Yes.
What was the light bulb moment for you that made you switch?
It was within about 3 months, but the light bulb was when I had a patient just accept a $50,000 FMR case. And in the same day had someone not accept a $3,500 sleep appliance that's going to save their life because medical wouldn't cover it. I mean,
that's a heck of a light bulb.
It's like, wait, what? Like, and consistently, that was my practice. I mean, I was in practice for 26 years. My patients trusted me. So they were writing checks for comprehensive care.
Yeah.
And it just happened that day that to like, oh wow, let's celebrate the $50,000 case acceptance with the check. And then wait, what was the challenge we had that day? We couldn't help move this patient forward because they were so stuck in that insurance thinking rut, because we led them that way. We collected their driver's license and their medical insurance card first. And then we talked about medical insurance before we even talked about a solution to the issue that they had.
Yeah.
Yeah.
Yeah. Cool. So I'll kind of summarize a couple of the questions. If somebody wanted to learn more about this, like they're doing sleep, but they want to know more about a fee-for-service model and the workflow, where do they get that? Well, that's a nice, perfect question for your next slide.
Yes.
So thank you guys for asking, but yeah, so we do courses. I'm sure some of you, if not most of you on here, have seen our webinars before. We do teach weekend courses. We try to do some of the least expensive, funniest sleep courses around. The emphasis, honestly, is on the soft skills, guys. You've heard the definition of AHI, RDI, all that kind of stuff. Those definitions don't change in our courses. How you talk about them does. How you quote treatment and work on payments instead of total fees. How you have a comprehensive package instead of nickel and diming every time you see the patient. If you're looking for some more information like that, this is a great place to go because we spend the weekend talking about it. And I do have one update. This slide was not updated with our most current special. We just had our newsletter go out this morning to our email audience. And until Friday this week, it is 50% off. So it's $400 instead of $800 or whatever half of $797 is. No, nobody knows. Just kidding. Everybody with an iPhone knows, except for me.
That's amazing. And I'm going to interrupt because you're not thinking from the dental office perspective, but this is a virtual course that dentists can do from their office and you can have your team attend. Dental sleep medicine is team driven. You could do the course as a dentist, but if you don't have your team next to you learning the same thing the same way,
yeah, so you can't do it in your PJs because it's not like this webinar. We can see you on that course. Well, so please make sure you're dressed, at least the top half.
Yeah.
Yep. So yeah, thank you for that, pointing that out. Virtual course. Separate from that, Mona, if you want to keep going in the slides, if you've got questions, we've got answers. I don't know. That's the maybe. What we know really well is this. It's sleep treatment, dental sleep medicine in your practice. If you're doing medical billing and you're stuck, we'd be happy to try to unkink that hose for you. If you are trying to figure out how to go from medical billing and the rut that you're in to a fee-for-service model, whatever it is, if you guys have questions that didn't get answered on the webinar, this is a QR code or that link will put you to a calendar on our website. You can ask a coach any question you want, and we'll give you 25 minutes of time for free. So it's a free consult. If you guys have questions, we'll try to answer them the best we can. If the answer is I don't know, the answer is I don't know, but we know who knows. And yeah, so that's the last thing there. And okay, back to our questions, and there's more now. Somebody asked, what's the new ADA code for oral appliance therapy? I do have that. It is D9947, but who cares? Kinda.
Yeah.
They're not paying for it, y'all. They're not going to pay for your oral appliance and dental insurance. Delta already knows how to not pay you for everything else. So the reason why it's there is for tracking in your dental software. It is not to get paid from dental, just to be clear.
Because everything should be tracked in your dental office. That's how you measure your success, right?
Yep.
So before this, you would have these codes that you would just make up dummy codes that are non-insurance codes in your software. But this now is in there, and it's great to be able to have them already there.
Yep. Okay, so what did you mean that medical insurance may be affected by my status with dental insurance?
So if you decide to be in network, if you apply to be in network with a medical company, there are some insurances that might actually apply that to your dental part. So if you're not participating with, so say Blue Cross Blue Shield, if you're not participating in their dental insurance, but you become in network with them for medical, you could automatically be enrolled to be in network with them dentally, and that will change your fee schedule.
Yep. Yep. And vice versa. If you are in network in dental and you have no idea what the in-network fee schedule is in medical for appliances, and you intend to bill out of network, that's actually a no-no in those same states that have that reciprocity. Yeah. So just if you're billing in network for either, be very careful if you're trying to bill out of network for the other, and make sure that you're not violating a contract you don't know exists because it was fine print in the one that you signed.
Yeah.
Yeah.
So, yeah, I mean, I think what I hope that everyone's taking home is that there's so many little details that you have to be aware of. And, you know, at the beginning, stepping into this field, maybe it's good not to lean on that so much until you really get your dental medicine process rolling. And then you can decide, is medical for you, in network, out of network, doing it from your office, using a third-party medical billing.
Yeah. So we've completely destroyed medical billing. No, I'm just kidding.
No, don't get me wrong. Like I used a hybrid plan, you know, once I got comfortable with the flow, and I think that's a really good alternative for a primarily dental restorative practice doing sleep medicine.
Yeah. So I'm going to push a couple of questions together because they're kind of asking the same thing. What scenarios would you recommend medical billing? And separate, this kind of weaves into it. There's a doc on here that's DSM only, trying to work with local MDs. They really want to work with somebody that's doing bills medical insurance.
Yeah.
You check the box.
Yeah.
What scenarios do you think medical billing is appropriate and you would do it in that scenario? And then what would you counsel this doc to do in his scenario?
So I think the answer to both is the same. Once I got comfortable and I just basically collect my cash fee with my comprehensive airway package. And then in the meantime, my team, the layer that we added on was that prior to that, they would have done a verification, and they would know if that patient has eligibility and needs a pre-op. And then at the close of that consultation and the financial conversation, they would say, we looked up some of your medical details. You've signed up for the comprehensive package. But in the meantime, if it's okay with you, we'll look a little bit into the medical. How does that sound? Patients like, oh my gosh, you're doing me a favor. They're so excited. And then, you know, they'll do their checklist of checking what's covered, submitting what they need to. We used a third party service, because I wanted to keep my staff. I didn't want to lose them. So I didn't want to have extra work. So, and like I said, if the pre-auth came back that there were benefits, they would have that conversation with the patient. But the great thing about this is you're collecting a fee ahead of time. You're not waiting until you deliver, right? When you are working with medical insurance, you can't submit for the actual appliance until the delivery, right?
Yep.
So you've gone through all those steps and you've not even submitted one thing. But if you do a fee-for-service model, you collect your fee, and then you go ahead and do the medical, you're not really chasing down patients for money. Yeah. And I see George has a question, like, with your cash fee, do you use third-party financing? Absolutely. Do whatever. It's like making a financial arrangement for your dental treatments, right? Yep. If a patient has a $5,000 treatment plan and their insurance covers $1,000, are they going to finance the $4,000? Yeah. And if that's what they want to do with your fee for your appliance, absolutely. Because remember, you're always winning because your team's driving it. The amount of time, if you're doing a specific implementation process like we teach in the courses, your team is doing all of the work. The time that you're spending with a patient is only at a specific time. You're doing restorative dentistry otherwise, or consults or more sleep stuff. Yeah.
Yep. So Tony has a question about fees. And yes, since we're on a public and recorded webinar, let me be very clear. Everything I'm about to say is in no attempt to set your fees. We're a national coaching company. We cannot do so, et cetera, et cetera. We can't do that. We don't want to do that. Let me give you some data to answer your question. What we see as a coaching company across the country is billing to insurance anywhere from $1,800 to $6,500 as a bell curve. Yes, there's outliers. We've all heard of the people that are billing $12,000 and $600, but that's the bell curve, 18 to 65. If you're in a fee-for-service environment, your sweet spot is more towards the 28 to 4,500 range, depending on your demographic. Roughly on the fee-for-service side, we see people set it usually at this cost of a single unit implant. Soup to nuts, implant, custom abutment, crown, no bone graft, whether it's you doing all of it or an oral surgeon and you're restoring the implant. I hope that was fast enough and detailed enough for you, Tony, to help you out a little bit. Yeah, we don't want to set your fees. We can't do that. We have no intention to, but make sure that your fee is in line with your area. Even if you're basing it off of that implant case, like I said, it's always going to be less than a full clear aligner case that's 12 to 18 months long, usually about 15 to 20% lower. Again, that's on the fee-for-service side. If you're a network, somebody else sets your fees for you, but they set them for their benefit, not yours. So make sure you are counting the cost of that. All right. Wow, we are on the hour. We are always over, and we are only at 6:02 right now. Pacific time, 9:02 your time. I know. Yeah, you're almost a pumpkin. Yeah. All right. Cool. Well, Mona, you got a compliment from Tony. Oh. Yeah. Thank you for the kind words, Tony. We're happy to be a blessing to you. And we're honestly, guys, we want to see you do better work, more work, better work for patients. Better just means you're helping more people. And shoot, if finances is in the way, schedule a free call with us. We're happy to help you guys if we can. If something tonight was the light bulb, fantastic. We're stoked for you. This is why we do this stuff. We want to put it out there and help you guys do more work. And we appreciate you hanging out. Mona,
thank you.
Any closing thoughts on your end?
No, I mean, really keep it simple, silly. Keep it simple, go save lives. And, let's not get bogged down with all the stuff that can stop you from really enjoying helping your patients.
Yeah. All right. And I would be remiss if I didn't say it one more time. If you guys want to attend a course, go pick one. Every one of the courses for the rest of the year is 50% off. Go grab a date. And we're not the company that's going to say, oh, forget it, you picked the wrong date, you can't have your money back. We'll switch dates for you if you want. But if you liked this, you'll love that. Come hang out with us for a weekend. We'd love to see you there.
Awesome.
All right.
Bye, everyone. Thank you so much for hanging out for an hour.
Oh, 50% by Friday. Don't call me on Saturday. Don't call me a liar on Saturday. It's only until Friday. Thank you, guys. Have a great night. We'll see you next time.
Bye. Cool.